Welcome back, ladies and gentlemen. We'll now be moving on to the 9th symposium on critical care and ventilation. We invite the chairpersons, Consultant Respiratory Physician Dr. Afla Sadikin and Consultant Respiratory Physician Dr. Niranjan Disanayaka to introduce the speakers.
Good morning, ladies and gentlemen, and we are into a very interesting and an important session today on critical care and ventilation in pulmonary medicine. And it's indeed a pleasure to invite the first speaker, Professor Narendra Bhatta, to talk to us about oxygen therapy in acute care.
Good morning. I'll be talking about oxygen therapy in acute care, and in the next 20 minutes I'll be discussing something about the contemporary concepts of the acute care, what exactly the acute care means, and some clinical and pragmatic approach to the oxygen therapy in acute care. Now, this is a very important topic, and it's quite commonly practiced in clinical medicine world over. So looking at what exactly means the acute care, let us discuss about the current concept of the acute care. If you look at the acute care, that means all care that is provided to treat the patients with the sudden, often unexpected, urgent and emergent episodes of illness and injury. Acute care is always a time sensitive, and if that is not provided, then there is a possibility of the death or disability in absence of the rapid treatment. That's the current concept of the acute care. Now, if you look at the more clear concept of the acute cares are mostly a time sensitive. They are regardless of any disease entity. There could be a multiple disease entity, but they are very time sensitive, and a patient is treated for a brief but severe episodes of illness in acute care. So acute care basically means the different etiology, but there is time sensitive care. Now, if you look at the more clear aspect, what are the different domains of acute care? Acute care have different domains. It could be an emergency care, it could be an urgent care, it could be a critical care, as well as the pre-hospital care. Sometimes the treatment of acute life-threatening medical conditions like acute MI, acute AE, COPD. It could be ambulatory treatment outside the hospital. It could also be a critical care, like the care which is provided in the ICU, and it could be a pre-hospital care. But all acute cares, the decision making is always a safer, better, and the better care. And most of the care are the time sensitive. Time is the most important issue. Etiology could be varied. Now, if you look at the concept of the acute care in oxygen therapy, many patients present with the acute care setting with the respiratory component of the distress. And most of these patients sometimes require the oxygen therapy. That's the basic gamut of the oxygen therapy in acute care. Acute care is a time sensitive, varied etiology, and most of these patients require the oxygen care. Now, defining what exactly means the oxygen care in acute care, oxygen therapy means when we provide the oxygen as a medical treatment. Oxygen has to be treated as a medical treatment in patient presenting with the components of the respiratory distress, irrespective of etiology. Etiology is varied. Time is the most important issue. So when oxygen is provided as a medical treatment in acute care, it is called as the oxygen therapy in acute care. I'll be focusing more about the oxygen therapy in acute care, irrespective of the etiology. Now, if you come to the more clearer concept, looking at the clinical gamut, there are no absolute contraindication of the oxygen therapy in acute care. Indications are just to be present. Now, important issue is the judgment. Judgment is something different than the evidence. Evidence is the components. Evidence are the components that help us to make the clinical judgment. If the clinical judgment is there, the patient requires oxygen therapy, there are no absolute contraindications. The clinical judgment is the most important aspect in the acute care. Now, if you look at the normal breathing, normal breathing is not very obvious. You have to look very carefully to a person to find whether there is normal breathing obvious. We breathe normally. There is no obvious thing. But if we look clinically that breathing is obvious, that means it is abnormal. If the breathing is obvious, that means the breathing is abnormal. Mostly normal breathing is not very obvious. You have to look very, very carefully clinically to that. Now, if there is the obvious breathing, there could be flaring of the nostrils, there could be tachypnea, there could be noisy breathing also. there could be use of accessory muscles, there could be pursed lip breathings, and there could be a chain stroke breathings. There are different components of the obvious breathing. Now, if the clinical judgment is there, there is no absolute contraindication for the oxygen therapy in acute care. Acute care is a time sensitive, right? Now, if you look at the another aspects, how do we do an oxygen assessment in the acute care? Most commonly, the oxygen assessment is done by the pulse oximeters. Pulse oximeters, they are simple, they are painless, they are non-invasive method of determining oxygen level. In acute care, the best possible parameters to look at the oxygenation, it will be ABG, but most of the time ABG could not be done in the acute care. So acute care, most of the time, is a pulse oximeter is there. Pulse oximeter means SpO2, saturation measured by the pulse oximetry. That's the most important thing. And the simple thing, if you look at the clinical rule, that's called a 4, 5, 6, 7, 8, 9 rule. If the PO2 is around, SpO2 is around 70%, PO2 could be 40. If it's 80, it could be 50. If it's 90, it could be 60. That means in healthy adults, SpO2 is around 96 to 98%. SpO2 value minus 30 will give you the clinically estimate of the clinically useful, what you call as the PO2 in the acute care. In the acute care, most commonly used things with the SpO2 and pulse oximeters. And if you look at the justification, how could you justify the treatment of oxygen in acute care? Most common justification will be hypoxemia is a marker of a risk, an independent factor for a very poor clinical outcome. So hypoxemia could be a risk also, and it could be a very, very important independent risk factor for the poor clinical outcome. Now that has to be, its clinical, what you call as the clinical impact of the hypoxemia will depend upon the underlying cause. There could be multiple cause. There could be the speed of the onset, how fast the hypoxemia onsets, how severe it is, and age of the patients, and the associated comorbidities. Therefore, it always justifies to prevent and correct hypoxemia and tissue hypoxia in acute care. That's always justified clinically. Now, again, oxygen therapy, if you look at the therapy of the oxygen, one has to understand certain terms. Most important term in clinical aspect is the FiO2, fraction. It's an estimate of oxygen content of the person that inhales. It involves the gas oxygen in the alveolar level. FiO2 involves the gas oxygen in the alveolar level, and it is almost always in atmospheric breathable oxygen is FiO2 is 21%. That means if it's 21%, it is 21% oxygen, rest is the another gases. Most often it's a nitrogen in the atmosphere. If we say oxygen FiO2 is 50%, that means there's a 50% oxygen. If we say FiO2 is 100%, that means it's 100% oxygen. Now, medical therapy as oxygen as a medical therapy is almost always it is about the oxygen FiO2 more than 21%. FiO2 more than 21% is a medical oxygen therapy. Now, we must all understand that medical oxygen is always a drug. Air is free, but oxygen is expensive and costly. Air is free, but oxygen is almost always expensive and costly. It's a medical treatment, it's a drug. That's why when we give the oxygen therapy, there has to be a correct patient, there has to be a correct prescription also. The patient has to be correct, the prescription has to be correct, there has to be correct flow rate, there has to be a correct device, and there has to be a correct connection to an oxygen source. The most important thing, because whenever we are prescribing a drug, there is a lot of responsibility for the clinician. And when we decide to give oxygen as a medical treatment, it must be always recorded and justified. That's a very important thing. It is always recorded and justified. It has to be clearly and honestly communicated to the patient what exactly we mean by this therapy and what could be the expectation. And it has to be re-evaluated regularly. That's very important. It has to be re-evaluated regularly. It's not that we give oxygen once and leave it. That's a very important thing. And if we come to the basics of the oxygen therapy in acute care, most often there are two situations. One, if the patient is not at the risk of hypercapnic respiratory failure. That means in the clinical practice, most of the patient will not be at the risk of the hypercapnic respiratory failure except for the certain cardiorespiratory diseases. Now in these things, whenever oxygen therapy is provided, we must set a target. The most commonly the target is 92 to 96%. That is the most common clinical indication, clinical target of the oxygen therapy in acute care when the patients are not in the risk of hypercapnic respiratory failure. In most of the clinical condition, most of the patients are not at the risk of hypercapnic respiratory failure. Now, how do we prescribe the oxygen? If the SpO2 is 85%, then one should use the reservoir mask. And if it is more than 85%, it's a nasal cannula could be the best one. And simple oxygen mask could be the best one. So before we prescribe the oxygen as a medical treatment, we must know about the different devices. What are the devices? How do they deliver the oxygen therapy? And what could be the risk? And how the patient could be benefited maximum out of that. In most of the clinical situations, in acute care, it's the patients are not at the level of risk of hypercapnic respiratory failure, and 92 to 96% could be the target oxygen saturation. Now, in certain cases, in a very severe acute COPD, there could be a patient could be risk of a hypercapnic respiratory failure, and then at that level, the saturation could be slightly on the target saturation could be maintained at a slightly lower state, right? And at this level, if FiO2 is more than 24%, it could be given by the venturi mask, and otherwise it could be given at the flow rate could be increased depending upon the various clinical situations. Now coming to certain other conditions, for example, common clinical practice, especially in case of acute myocardial infarction, oxygen therapy is generally given. It's a conventional teaching that one should give oxygen therapy, but again, there are a lot of research, a lot of clinical evidences these days that oxygen therapy giving an acute MI could be more harmful than the beneficial. Then issue is again about the hypoxia. If there is normoxia, then there is no need for the oxygen therapy, but if there's hypoxia, then again maintaining the saturation level at 92 to 96% is good. Same thing about the acute stroke. Even in the acute stroke, oxygen therapy is generally not required. But again, if there is a hypoxia, then oxygen therapy could be given, again maintaining at the level of 92 to 96% of the saturation level. Now coming to another important clinical aspect, especially in hyperventilation syndrome, especially young female patients, they'll be breathing deeply and fastly. In this patient, the mechanism is slightly different. So oxygen therapy could be given in the short term to relieve the hyperventilation syndrome. Third important issue in clinical practice, what we see commonly, is about the poisoning and overdoses. In the most of the poisoning, again, in the emergency and acute condition, oxygen therapy is given. But most important aspect is to give antidote first, rather than the oxygen therapy. That's a very important issue. Similarly, in case of acute sepsis, in acute sepsis also there have been a lot of issues regarding the oxygen therapy. Oxygen is given, but in acute, most oftenly it's to correct the multiple parameters that are important. Cardiac output and blood HB count rather than giving the oxygen therapy. If there is a severe hypoxia, then obviously yes, 92 to 96% oxygen can be given. That's very important. Now in acutely breathless patient, in acute care, that means acute care again, let me stress again, it's about the time sensitive, regardless of the etiology. In acute care, respiratory rate and the pulse rate and unexplained confusion and agitation are much more important clinical parameters rather than the cyanosis or hypoxemia. So important issue is again, always take a short and pertinent targeted history in acute care. Time is very, very important. Time is very sensitive issue. Initial oxygen therapy could be 2 to 6 liters per minute, and then again, regularly monitored. Saturation target most oftenly, again to stress, is 92 to 96% in acute care. Now there is another important aspect in acute palliative care setting. That's for all of the clinicians, for all of the clinical practice, breathlessness in acute palliative setting is very frightening experience for the patient as well as for the patient attendants. Now, oxygen therapy is given most oftenly on the basis of the intuitive assumption of the benefit. In acute palliative care, if the patient is very sick, breathless, then we always start oxygen therapy. Most oftenly, it's given on the compassionate basis. And it's treated as the caregiver's anxiety. The caregiver is so anxious that the patient is having breathless, so why not give the oxygen? He'll request the doctor to give the oxygen. But here there is again a caveat. Not using oxygen makes the suffering is very visible. If you don't give the oxygen, there could be a lot of suffering that could be visible. Nobody wants to make a patient suffer. But once the oxygen is given, it's very difficult to take the oxygen off. Nobody wants to take the oxygen off. But there have been a lot of studies from the patient side, caregiver side. It says that moving of the air in front of the nostril is slightly beneficial. It relieves the breathlessness, not necessarily oxygen. So most commonly, a simple tabletop fan is a very inexpensive and nice device to give in the palliative care rather than the oxygen therapy in the palliative care. But again, palliative care is a very different issue. There has to be a very fine balance of the medicine, mystery, magic, miracle, and compassionately. Most oftenly, the oxygen is given to relieve the dyspnea, but the breathlessness has a multiple components, and shortness of breath is only a subjective phenomena there. Now, if you look at the oxygen therapy in acute care, most commonly, if the patient is awake, this position is more beneficial and more comfortable, and it gives the oxygen more usefully in the patient, in the awake patients. Semi-Fowler position is the better in the acute care. Now, there is another gambit. Oxygen therapy is necessary for the patient for the hypoxia, but there is a risk of hyperoxia. Hyperoxia means there is excessive oxygen therapy in the tissues and the organs, and it's a continuous exposure to the very high oxygen level. Now, one must understand, hypoxia is frequently seen in the nature, in high altitudes, but hyperoxia is a man-made phenomenon. Human beings are not, the evolution has not given us the armamentarians to handle hyperoxia. We can handle hypoxia, but hyperoxia is generally dangerous. Now, oxygen is another issue. There's a lot of paradox in the oxygen, It's impossible to live without oxygen, but it will be extremely unbearable to live with oxygen also. Oxygen is very, very painful. It's very expensive also. It has a Janus phase. It's important for life. Energy conservation is life, but lipid peroxidation leads to death. And there is always a two-faced thing of the oxygen. Oxygen has a lot of paradox. Now, if we look at the life events, life is always risky. Mortality of the human beings is 100%. That doesn't mean that we can reduce all the risk to the 0%. So idea is that we have to go for the harm reduction rather than the complete risk elimination. That's the most important thing in the acute therapy, oxygen therapy. Now, if you come to the issues, the whole issue is about the individual targets. You have to assess the patient very carefully clinically. You have to target the SpO2 range. Most often is around 92 to 96%. And then hyperoxia also has a risk. Hypoxia also has a risk. And we have to achieve the desired oxygen level. And if it's very harmful, if there is hypoxia, if very harmful, it's hyperoxia also. But in acute conditions, hypoxia is more dangerous than the hyperoxia. Now, in hypoxic patients, any description, any kind of the description will require the oxygen therapy. So it will be very painful and unethical to deny the oxygen therapy in hypoxic patients. Once we give oxygen, we might protect the brain and the heart, but anyway, the patient might require assisted ventilation. So, on clinical rules of the thumb, hypoxia is much, much more dangerous than the hypercapnia or hypoxia acutely. So it all comes at the level of the clinical judgment. What exactly is the clinical judgment? And this clinical judgment is, it will be helped by the different evidences, by the SpO2 as well as the clinical parameters. Now, when to discontinue the oxygen therapy? Once we have given the oxygen, when to discontinue it? The most important thing is we can remember the rule of 2. We can stop the oxygen therapy in clinically stable patients if the target SpO2 is under 2 consecutive observation 2 hours apart. If we have fixed at the level of 92 to 96%, if it is stable at the 2 consecutive things within 2 hours apart, we can think of slowly discontinuing the oxygen therapy. And again, we have to monitor SpO2 on the 2 times in the first 10 minutes and recheck again. Whole issue is if SpO2 falls below that, we can again restart the oxygen therapy. That's more important thing. Now, this clinical decision making, over the period of centuries, it has come from the different polarized debates. First, what to do something. Then again, we come at the first, do no harm, just do it, and please don't do it. So it has changed over the different kind of paradigms, especially in the COVID-19 also. We have thought about what to do, then do something, first do no harm, and just do it. And over the period of years, with the clinical research, we have come to the issue of whether there has been paradigm shift. We have come to the level, first it was thought, more is more and less is less. Then the whole issue came about the more is better and less is less. Then again, the whole issue came about the more is more better and less is early on and less is less. But now, more is more and less is adequate and better. Less oxygen is adequate and better. That's the most important thing in the acute therapy, in oxygen therapy. Oxygen is a life-saving drug. Give only when it is necessary and needed. And don't give extra, because body can't store the oxygen for the future use. There's no point giving extra oxygen. Give only when it is needed. And next issue is about what is the pragmatic wisdom? What is the pragmatic wisdom in the oxygen therapy? There's no absolute contraindication if indications are just to be present. Judgment is the most important issue. Second is initial oxygen therapy at the level of 2 to 6 liters per minute by the nasal cannula. The target saturation always try to maintain at 92 to 96% in most of the clinical situations. And trends are the more robust than number. One single number of the SpO2 is not very important. Most important issue, the trend. What is the trend about that? And we should start low, monitor cautiously, go slow, but go. Now to end, I'm coming from the land of the Himalayas and from the land of the birthplace of the Gautam Buddha, the Siddhartha, the Gautam. And life should not be measured by the numbers of breath we take, but by the moments that take our breath away. Thank you, gentlemen. Thank you very much.
Thank you very much, Professor Narendra, for that thought-provoking lecture. So at the end of the session, we'll take up questions, and then we'll go to the next lecture. Our next speaker is Dr. Dilshan Priyankara, who is a consultant in critical care medicine, National Hospital of Sri Lanka. So he's not a stranger to us, and he'll be talking to us on ARDS, the new definition, and whether he's going to talk about whether there are any changes of management. Over to you, Dilshan.
Thank you, chairpersons. Good morning. So thank you for the Sri Lankan College of Pulmonologists giving me the opportunity to talk to you on this very important topic, and with new developments and new evidence coming up. So today I'm just going to give you a brief overview where we are today with the ARDS, and review the definition and the management to date and the future directions. So the best known early description of this problem came from this French physician who invented the stethoscope in 1816. And he described this gross pathology of idiopathic anasarca of the lung. At this time, the such anasarca characterized by severe shortness of breath and cyanosis was nearly fatal. And this landmark paper in 1967, the Ashberg and colleagues described this, the severe dyspnea, tachypnea and cyanosis that is refractory to oxygen therapy, and loss of lung compliance and diffuse alveolar infiltrates on chest X-ray. And this study was based on a case series of 12 patients treated in the civilian environment in the USA. So this was the starting point to recognize this entity called ARDS. So the first definition came up in 1994. So the nomenclature of ARDS continued to evolve. And in 1994, this first definition came. This is a consensus. This is in the American European Consensus Conference, and they published this specific criteria for diagnosis. So what they said, it's an acute one where your imaging showing bilateral alveolar interstitial or interstitial infiltrates, and the pulmonary capillary wedge pressure less than 18, or with no evidence of left atrial higher pressure, and also with the PF ratio less than 300, and they divided into acute lung injury as well as ARDS if the PF ratio is less than 200. So in 2012, a panel of experts revisited this criteria for ARDS diagnosis, and the result known as the Berlin definition in ARDS, which is very similar, but it's more specific. So the problems they addressed from 1994 definition, what is acute? So just want to talk about why they wanted to change this, because it was a great definition, but there were problems in the previous definition. Bilateral pulmonary infiltrates were vague. We need to be clear about what we define by bilateral infiltrates. And the pulmonary capillary wedge pressure less than 18. Obviously, they didn't want the patients to be who are in cardiogenic pulmonary edema to be included. But actually, when you look at the patients with low pulmonary capillary wedge pressure, that was a lousy definition. So this is a very good example. This study looking at fluid strategies in patients with ARDS, whether they were dry or wet, and 30% of the patients who had pulmonary capillary wedge pressure more than 18. And despite the fact of patients, 97% of them had normal cardiac index. So it was a lousy definition, including the pulmonary capillary wedge pressure into the definition. Then again, the impaired gas exchange measured by PF ratio. So everyone with PF ratio less than 300 has acute lung injury, and everyone with PF ratio less than 200, do they have ARDS or do they have acute lung injury plus ARDS? So that was question. So that's why they changed this definition, including these criteria. So timing, so what is acute? So they said it's within 1 week. And chest imaging, which are bilateral infiltrates, not fully explained by effusions, lobar lung collapse or nodules. And the edema, they ruled, they can taken out the pulmonary capillary wedge pressure and they included that you had to rule out a cardiac cause or cardiogenic pulmonary edema by assessment, especially using the echocardiogram. And also the oxygenation criteria, they have divided into mild, moderate, severe, and they ruled, taken out the acute lung injury part and included the PEEP. So that was the Berlin definition. So the question now, when you have a non-ventilated patient, how can you apply PEEP? So how can you define a patient whether they are in ARDS or not? So including patients with nasal high flow, the question is whether you can permit or early identification of the natural process. On the other hand, you may select patients with a lower mortality, which may affect your recruitment for future studies who may have a lower mortality. So in the new guide, that's in 2023, they included the term acute hypoxemic respiratory failure, where you want to include the patients who want high flow oxygen therapy. So ARDS pathology, I think probably all of you know, there's an inflammatory process going on in the alveoli. There's infiltration of WBC, alveolar macrophages, cytokines, denuded epithelium, thickening of alveolar capillary membrane, and fluids and proteases, and finally with fibrin causing difficulty in ventilation. So that's the classic, the natural history of this. If you take a biopsy, this is what you see. It's the diffuse alveolar hemorrhage. Causes of ARDS, I think probably all of you know. The other thing is ARD is not a disease, it's an entity or a pathological changes that occur secondary to something else. So if you look at the numbers, the epidemiology is an important trial looking at 29,000 patients who are undergoing mechanical ventilation, published in 2016. What they found, ARDS is common. 10% of ICU admission and 23% of patients who are ventilated have ARDS. But the rate of recognition was low as 60% of them were identified during the clinical course. They could not identify them early. Again, mortality is still a critical challenge. So the hospital mortality reported in these many epidemiological studies after the 1994 definition. So the figure A shows all ARDS categories where mild, moderate, and severe, where the figure B shows the subgroup of moderate to severe ARDS category. Still, it's high. So in the lung-safe study, they looked at this mortality, where depending on the category of mortality rates goes up close to 50% if you have severe ARDS. But remember that the patients don't die of ARDS, they die with ARDS. So patients will die of the underlying cause, but at the time they will have ARDS. So coming into management, the two things I want to tell, there is no specific biological therapies for ARDS at the moment, and treatment is supportive and preventive, prevention of lung damage. So during the last couple of decades, people are looking at how to oxygenate these patients, how to ventilate these patients. At the same time, you prevent lung injury. So one of the ways that we can induce ARDS is overdistension, and it worsens your inflammatory injury. So once you induce high volume and overdistension, you get an injured lung. This was one of the animal studies. So you look on your left-hand side, you can see the normal lung, but if you give a higher pressure, you end up with a lung on your right. So you can induce ARDS by overdistending the alveoli. This is a classic CT scan of a patient with ARDS. You see the dependent edema or the consolidations that you see with on the top, you see the baby lung. So when you ventilate these patients, you give the same amount of pressure to both parts of the lung. So when this positive pressure is applied to aerated as well as non-aerated lung. So the problem comes when you give the pressure that is distributed to the baby lung that can cause overdistension. So that's the thing that we have to worry about, which cause ventilator-induced lung injury. So for that, this was the landmark trial, came up in, published in year 2000. So this was a starting point of protective mechanical ventilation, the ARDS network trial. This was done on close to 900 patients where they randomized 6 ml per kg as well as 12 ml per kg, and they found there's a significant mortality reduction when you ventilate them with low tidal volume. And it has become the standard of care in patients with ARDS. And not only ARDS, now even for normal patients that we apply this. Again, in the study, they looked at the patients who had 6 ml per kg versus 12 ml per kg. If you look at this graph, in the initial days, you see the oxygenation is better with patients who had 12 ml per kg, but ultimately they coalesce together. So it's like a trade-off. You see an improvement of oxygenation, but on the other hand, their mortality rate goes up. At the end, your oxygenation PF ratio is almost the same. So that's about the lung protection. And these are new things that came up in 2023 guideline. They included the nasal high flow because during the COVID era that we used nasal high flow and NIV in most patients. So they recommended who are non-mechanically ventilated to use nasal high flow over conventional oxygen therapy. And they recommend to apply high flow for the COVID patients as well, but they are unable to make a recommendation for or against the high flow over conventional therapy to reduce the mortality. But they to reduce the intubation rates, but it does not reduce the mortality. Again, they are unable to make a recommendation for or against the use of high flow nasal oxygen to continuous positive pressure ventilation or NIV to reduce the intubation rates or mortality in patients with acute hypoxemic respiratory failure. But they suggest NIV or CPAP in patients with COVID-19 to reduce the rates of intubation. So NIV, when it comes to NIV, again, they were not able to make a recommendation for or against the CPAP NIV compared to conventional oxygen therapy to reduce mortality or to prevent intubation. But they suggested the CPAP therapy over conventional oxygen therapy in COVID-19 patients. So ultimately what they said, if you have a hypoxic respiratory failure patient, you can provide nasal high flow. If you have a COVID patient, the NIV, you can use NIV over high flow to reduce the intubation rates, but none of them reduce the mortality rates. Coming into PEEP. Now, this is a pressure volume graph looking at the compliance. So you see 3 zones where the atelectatic trauma occurs. Where if you imagine you are blowing a balloon, the initial bit is hard, where the alveoli collapse. Then you come to the safe zone where the compliance is best, and then you come to a zone where you over-distend by giving more pressure. So PEEP keeps alveoli open and prevent collapse, and using higher PEEP may keep stiff alveoli open and prevent collapse. So one thing, it prevents collapse as well as reduce the atelectatic trauma. So now people looked at whether you are giving high PEEP or a low PEEP, which one is better. So there were 3 studies looking at high PEEP in ARDS, and none of them showed a significant mortality outcomes. The studies were alveoli and Express and Loves, the landmark trials. But so this is a meta-analysis published in 2010. They looked at these 3 studies together. So when you looked at the 3 studies separately, there was no significant difference. But when you put all 3 studies together, there was a significant mortality benefit in moderate to severe ARDS group when you apply higher PEEP. So this was recommended in 2017. But later on, the ART trial came. So they were still uncertain of this optimal PEEP. of these patients with ARDS. However, specific subgroups of ARDS patients may benefit from open lung ventilation with recruitment maneuvers, but identification was uncertain. In the R trial, mortality was higher, significantly higher in patients where they use mechanics-based ventilation. So this ultimately, looking at all these studies, they recommend that they are unable to make a recommendation against use of routing higher PEEP titration versus lower PEEP FiO2 strategy. So still it's doubt. Again, the respiratory mechanics that especially with transpulmonary pressures, you apply your PEEP, but still again, they are unable to make a recommendation against the PEEP titration guided ventilation over the low PEEP FiO2 strategy. Recruitment. Recruitment is basically you recruit the alveoli which are collapsed. Now, people were, especially with the ART trial, there was patients who died of recruitment maneuvers, so they recommend against the use of a prolonged high pressure recruitment maneuvers and the routine use of brief high pressure recruitment maneuvers as well because of hemodynamic collapse. Prone ventilation, yes. So the effects during prone ventilation, you flip them up, down. So there will be a great expansion of ventral alveoli compared to the dorsal alveoli. The compression of the heart is ceased, and as well as the diaphragm. So what you're going to do, you perfuse the ventilated alveoli. So this is a very important strategy where you can improve oxygenation. So there are a few RCTs looking at the prone position ventilation, and this is a prospective multicenter RCT with the well-known PROSIVA trial. They looked at close to 500 patients who had severe ARDS, PF ratio less than 150, the PEEP of more than 5, had a significant mortality difference. And there were several meta-analyses on prone position ventilation showing mortality benefit in severe ARDS group. However, this meta-analysis assessing close to 2,000 patients, the overall prone position was not significantly associated with the risk ratio to death. But when they stratified the high and low tidal volume groups, what they found there's a decreased mortality rates in patients who had low tidal volume. So what does it tell is not just proning, your ventilator strategies are also important when you go up on the ladder. So recommendation is we recommend using the prone position as compared to supine position patients with moderate to severe ARDS. So still it's valid. Now the awake prone positioning came up in 2023 guide. This basically came because the COVID-19 era. So they suggest awake prone position positioning as compared to supine in patients with COVID-19 with acute hypoxemic respiratory failure, which will reduce intubation rates, but they are unable to make a recommendation on non-COVID population because there's not enough studies on that. Neuromuscular blocking agents, we're going to paralyze these patients. So this is a multi-center double-blind study with patients with severe ARDS looking at PF ratio 150, less than 150. So this study showed that it could be utilized safe in severe ARDS patients where they showed a 90-day mortality was better when you use cisatracurium in patients with severe ARDS. Then this ROSE trial came and demonstrating a non-significant result. They used the same, but it did not show any mortality outcome. So recommendation is that you don't need to use routine continuous infusions of neuromuscular blockade to reduce mortality in patients with moderate to severe ARDS, not due to COVID. So this came up in 2024, the steroids. The drug, we commonly use and we are intended to use when the patients are bad, isn't it? So they updated the guideline on sepsis, acute respiratory distress syndrome, and as well as the community-acquired pneumonia. So looking at overall all the studies, they suggested to use steroids in either as dexamethasone or methylprednisolone in early ARDS or patients who have unresolving ARDS. So these are really sick patients actually who have severe ARDS going up on the ladder still. So there is a place for steroids in ARDS. ECMO. So most of the studies were case studies. This is a well-known RCT, was the CESAR trial. So they looked at 180 patients who were randomized, and it showed a mortality benefit. But there were problems in the randomization of this trial. So then came the EOLIA trial. So their primary endpoint at the 60-day mortality with patients with severe RDS showed no significant benefit with early ECMO. So there was a crossover of patients who had hypoxic respiratory failure who were not doing well with the conventional ventilator strategies. So looking at all of the studies, so the recommendation is that the patient with severe RDS, not due to COVID-19, so if you want ECMO, go by the eligibility criteria and at specific center. So center also matters when you look at if your patient is going for an ECMO. So last 30 seconds, I'll sum up. So things tried but failed. Several things which have tried but failed. So what our understanding on ARDS over these 50 years, or more than 50 years, there's been change in the definition. I'll probably feel that it might change in the future to include the patients who are non-ventilated. An understanding of mechanical ventilator strategies to prevent the lung injury. Still, it's there's a lot of uncertainty of certain things. So we might see several trials looking at different aspects. And what other things like proning, supplementary strategies. So it's not the end of the story. The future, looking at the prevention of low tidal volume, no sedation with the gene therapy, because now they are identifying several phenotypes of ARDS. One person who has an ARDS may behave differently to another person who has an ARDS. So phenotypes, either clinical or biochemical phenotypes. So your ventilator strategy is higher PEEP, whether you're lower PEEP, whether you're steroids, whether the patients who are hyperinflammatory. So all these might come up. So this is where the era that we go on to individualized or personalized treatment. So with that, I would like to end my talk. Thank you very much for listening.
Thank you, Dilshan, for that excellent presentation. And now we'll move on to the next lecture. And it is indeed my pleasure and honor to invite Dr. R. Vijaykumar, Consultant Pulmonologist, Pulmonary and Critical Care Director of Pulmonary Academics, Yasoda Hospitals, Hyderabad, India, to deliver his presentation on role of NIV in respiratory care.
Respected chairpersons, I'm extremely thankful and privileged for the invitation by the Sri Lanka College of Pulmonologists, especially the president, Dr. Bodhika, fellow faculty, delegates, ladies and gentlemen. In the next 20 minutes, we are going to discuss about a very historical milestone which happened in the management of lung diseases, and that is non-invasive ventilation. Now the non-invasive ventilation has spread not just in the critical care but also outside the critical care, which is probably, we'll take it up some other time, but we'll focus our attention for the critical care and NIV. I come from a city called Hyderabad, which is known for the huge Buddha statue, which is a monolithic statue, 350 tons, has been there for the last 5 years, has taken 5 years to make it at a cost of $3 million US. The stone was carved out of a huge stone mountain, and then it was transported 46 kilometers to be placed in the middle of a lake. While transporting the statue to the middle of the lake, the statue rolled down and fell down into the lake and stayed there for 2 years until a lot of physics was applied, and then it was floated up, and then now it stands there as a tourist attraction. So coming back to the subject, a lot of interest and a lot of review articles about the clinical applications of non-invasive ventilation in critical care. I got interested in non-invasive ventilation quite early on, and then I have no qualms at all, and I have no doubt in my mind that non-invasive ventilation works. The stimulation for non-invasive ventilation came when I went to Sydney to work for some time with Professor Colin Sullivan, who was working on this particular contraption in those years, especially for sleep apnea. And it got extrapolated automatically to the other issues. And even today, Colin Sullivan is working on a lot of research on the fetal sleep apnea. Now, the stimulation for the non-invasive ventilation came because of the disadvantages of mechanical ventilation. I started getting involved in the invasive mechanical ventilation way back in 1992, and I could see a lot of disadvantages. Expertise is required. I had to get trained in intubation and ventilation. There were more infections. Patient is extremely at discomfort. Huge cost for the patient, because most of the patients in India, they pay from their pockets, and more staff is required to take care of them. And complications apart from the infections like pneumothorax, blocked endotracheal tube and things like that. And with all this, there is a higher mortality, and the patient stays in the ICU for a longer time, patient stays in the hospital for a longer time. So all these disadvantages became the advantages for the non-invasive ventilation. It avoids all the complications of the endotracheal tube, it improves the patient comfort, preserves the airway, defense mechanisms, and what is important for both us as well as the patient is it will bring down the number of days in the hospital, and it will bring down the cost of treatment. So where do we exactly use non-invasive ventilation in critical care? There is a huge list. But most patients fall into two categories. There is acute exacerbation of COPD and the cardiogenic pulmonary edema. But then in selected patients, we can still use non-invasive ventilation. As you gain more experience in using the non-invasive ventilation, the indications will start increasing in numbers. And whatever the initial researchers did, they eliminated all the complicated cases and applied their NIVs on safe, unquote, quote unquote patients. And that's the reason why the indication, they were all the contraindications. But then as you gain experience, you will become more bold, more courageous, and start applying the non-invasive ventilation in virtually in all cases, starting from post-extubation failure, community-acquired pneumonias, immunologically compromised patients with infections, etc. Now, today, in the next 18 minutes, I would restrict myself to talk about acute exacerbation of COPD and NIV and cardiogenic pulmonary edema. So, the absolute contraindications, just to fill up the gaps, would be cardiac arrest, obviously, coma, arrhythmia with compromised hemodynamics, shock with major organ failures. Since we place the NIV mask on the face, any injury, trauma to the face is a contraindication, and severe deformity of the face because the NIV mask has to sit on the face, and upper airway obstruction, obviously. These are the common sense absolute contraindications. There are some, of course, relative contraindications, such as patients who doesn't want a NIV mask, confused, agitated, uncooperative, a lot of vomitings because we have to keep removing the mask every time, copious secretions where patient has to cough and expectorate, and very severe acidosis less than pH of 6. So as far as the cardiogenic pulmonary edema is concerned, let us have a quick look at the pathophysiology. We know that because of the oncotic pressure and the hydrostatic pressure, there is an increased flow of water into the interstitium. Interstitium swells up, impairs the oxygenation, and that is where the NIV works. And you can see it brings this particular fluid in the interstitium, brings down the lung volume, brings down the compliance, airway resistance increases. As a result, the work of breathing increases and the oxygen cost of breathing goes up. So if you compare the normal lung and the cardiogenic pulmonary edema the two hearts look very different because the size are different of the, especially the left ventricle. One of the earliest supports for NIV in cardiogenic pulmonary edema came from this particular group, and which was published in New England Journal of Medicine with almost 1,000 patients. It was an open, multi-center, randomized clinical trial. What they did was they divided the patients into 3 groups: the oxygen group, the CPAP group, and the BiPAP group. The endpoint was either death or intubation in 7 days. And what they found was there has been no difference in the death and intubation rates, but those patients who were given the CPAP and the BiPAP, there was a faster resolution of the dyspnea, hypoxia, hypercapnia, acidosis, and the heart rate. Then came several other studies which looked at non-invasive ventilation, and there was this particular review article followed by a Cochrane review which was published 10 years ago. What did the Cochrane review say about this? They looked at nearly 32 studies, almost 3,000 patients, and they said non-invasive ventilation in cardiogenic pulmonary edema definitely reduces the mortality, reduces the intubation, reduces the length of stay, and reduces the ICU stay. And there has been no new cardiac events, because that was one of the accusations from some people, that those who are on NIV will get a new cardiac event, but that was not the case. So everything good, everything hunky-dory. So as a result, the ATS and the ERS produced their guidelines on non-invasive ventilation for acute respiratory failure, and they said, yes, thumbs up. But then how does the NIV act during cardiogenic pulmonary edema? It improves the functional residual capacity, improves the alveolar recruitment, reduces the intrapulmonary shunt, improves oxygenation, better lung mechanics. What else do we want? So any patient being wheeled into the ICU or into the hospital with a diagnosis of cardiogenic pulmonary edema should first be put on NIV. 90% or more than that would definitely improve, and those small minuscule percentage of patients who don't do well not because of the NIV failure, but because of the other comorbid conditions, they perhaps may have to go on to the regular mechanical ventilation. Now we switch gears and then move on to the acute exacerbation of COPD, and the advantages again in this particular area is decreased need for intubation, reduced in-hospital mortality, reduced hospital stay and the cost, and improvement in the pH and PaCO2. That is what we want in acute exacerbation. And it works very fast. Within 2 hours, you will know whether NIV is successful or not in acute exacerbation of COPD by doing an ABG at admission. doing another ABG after 2 hours of NIV that predicts the success. So one of the largest reviews was done by Keenan, where he looked at a huge number of studies, and he surmised that the intubation rate can be brought down by 1/3, mortality by 10%, and the length of stay in the hospital is almost 5 days. And those who are paying from the pocket, 5 days of cost is a huge thing for them. Not only that, this particular review also said patients who have the severe COPD, in fact, they benefit even more. The severe COPD, where the pH is less than 7.30, intubation rates are less, mortality is less, and the length of stay is also much less. So the Cochrane review again looked at 14 studies, and they agreed with all the previous studies that the mortality is reduced. More importantly, the need for endotracheal intubation can be brought down. So complications are less and hospital days are less. But then, experience has taught us that there are 7 predictors of failure when you apply the NIV in acute exacerbation. The lower the arterial pH, the success rates are less. Apache scores, obviously, if the patient is very sick, then again, do not expect great results. Inability to cooperate with the machine, somebody who is claustrophobic, doesn't want to use a mask, doesn't like the pressure of air hitting him, and inability to minimize the mouth lick, taking a long time to correct the pH, carbon dioxide, and respiratory rate. As I said earlier, 2 hours is the time when we measure a repeat ABG to decide whether the patient is benefiting or not. And patient who had poor quality of life and activities of daily living before admission, they don't do very well. And those who have multiple comorbidities like diabetes, sepsis, etc., also they don't do very well. Now, the next 2 slides are my favorite slides, which shows that in the non-invasive ventilation, especially the bilevel positive airway pressure machines, the inspiratory positive airway pressure is important, followed by the expiratory positive airway pressure is another very important setting that we do. And the difference between the two is the pressure support, which drives the tidal volume. So we need the tidal volume to drive out the carbon dioxide. So tidal volume multiplied by respiratory rate is the minute volume. Greater the minute volume, greater is the washout. So these patients who have hypercapnia, they have to wash out the carbon dioxide. So 20 by 15 IPAP by EPAP is not good because the pressure support is only 5. But 15 by 5 is good because the pressure support is very good. So the rule is EPAP should always be 1/3 of the IPAP. So again, this is a very important publication which has come, where they looked at the success of NIV in this particular indication, nearly 1,162 patients. This paper shows that please follow the guidelines. If you don't follow the guidelines, you will end up in greater mortality for the patients. So they have taken almost 668 patients for the study after eliminating some of them. 106 were on NIV and 27 were not on NIV. So to analyze it further, look at this. At the time of admission in the hospital, 78 out of 78 patients in the hospital, mortality was 14%. At the end of 3 months, it was 23%. And those patients who were not put on NIV at the time of admission, the mortality was 23%, and after 3 months, it was 47%. So what happens? This is about admission. What happens during the hospital stay? During the hospital stay, patients who deteriorated, and NIV was put, there were 28 people, and in-hospital mortality was not as good as it was at the time of admission. It was 21%, and at 3 months, it was nearly 50%. But those patients who were never put on non-invasive ventilation despite the patient deteriorating, 50% in hospital mortality and 83% at the end of 3 months. So this goes to show that NIV has to be started at the right time, follow the guidelines. So let us spend a few slides on what are the machines that we have. Long time ago, the NIV machines were not that good, but now they are as good as the ICU machines. They show everything, all the monitors, all the alarms, and they have all the modes, and they have chip-based algorithms. They can display the fraction of inspired oxygen as well, and they can run on batteries if any patient has to be shifted from hospital to hospital, city to city, or we got patients from different places for lung transplantation on NIV to Hyderabad. So there are two very important machines. One is the continuous positive airway pressure machine. You can see them in the stalls here. Another is the bi-level positive airway pressure machine. Now, more important or equally important as machines are the interfaces. They are the masks. We have a lot of masks. Most of them are from home use, but the one particular mask, this is the nasal mask, this is the oronasal mask, this is very good in the hospital, in the ICUs. Of course, just for completion's sake, you have the full face mask and you have the helmet mask also. We should be extremely cautious when you are putting the mask on the face of the patient. Too much of pressure, if you tighten the belt, this is what happens. There is excoriation of the skin, and the patient will curse you throughout her living life. So what's the solution? The two-finger rule. Put 2 fingers, and then on top of that, loosely strap the mask so that there is not much pressure. You can also use this kind of adhesive plasters. And when the patient is on this NIV mask, you can do a lot of things. You can give oxygen, you can give nebulizers, you can give meter-dose inhalers, and we keep performing bronchoscopies with the NIV mask with a light sedation like midazolam. This is the special mask for doing bronchoscopy when the patient is on NIV. So bedside monitoring is very important. You look at the general demeanor of the patient, consciousness levels, Glasgow Coma Scale scores, whether the patient is comfortable or not, expectorations, vomitings, we need to keep check. And of course, we have to check all the vitals, important, and make sure that there are no leaks in the mask. About 5% to 10% of the leaks are accepted, but more than that, you have to check for something, because most machines are capable of compensating for the leaks. Blood gases, as I said, 2 hours after the initiation. What do you see after 2 hours? The carbon dioxide should come down and the pH should improve. Weaning criteria, of course, whatever was bad at the time of admission, at the time of initiation of the NIV should get better. And last couple of slides, just to summarize the key points. Avoiding mechanical ventilation and the complications that follow is the biggest achievement of NIV. That's why I call it a historical milestone in the medical management in the acute care. And strongest evidence for use of NIV is for type 2 respiratory failure and cardiogenic pulmonary edema. NIV is emerging as an alternative to mechanical ventilation in a number of indications. The more you do, the more you experience get, more courageous you will become. If NIV is initiated outside the critical care, a defined plan should be in place just in case it fails. NIV should not delay intubation and mechanical ventilation. And in patients who don't improve or deteriorate on NIV, we have to immediately intubate and ventilate. That's my last slide. Thank you very much for your patient hearing.
Thank you very much, Professor Vijay Kumar, for that overview of importance of NIV. Now, we are at the last lecture. There is nothing complete when it comes to critical care of a patient who is critically ill if we are not doing anything nutritionally, and we can't expect a good outcome. So, to talk about nutritional care in the critically ill patient, we have Dr. Sajitha Mallawarachi, who is a consultant clinical nutrition physician working at National Cancer Institute, Sri Lanka. Over to you.
Thank you very much, chairpersons. Okay. Today my talk is on nutrition care in critically ill. I would like to thank Sri Lanka College of Pulmonologists to giving this opportunity, and Sri Lanka College of Nutrition and Physician and Sri Lanka Medical Nutrition Association. Okay, this is the outline for my presentation. Okay, what are the objectives of nutritional treatment? Secure adequate and optimum intake of energy, proteins, and macronutrient and micronutrient. Diminish metabolic disturbances and reduce symptoms due to the nutritional impairment. To optimize nutritional status, enable undergoing planned critical care treatment, and for uninterrupted critical care follow-up plans. Nutrition is very important for uninterrupted critical care follow-up plan. Okay, why importance of nutrition interventions? Every critical ill patients will stay more than 48 hours in the ICUs are nutritionally at risk. Avoid ventilator dependency and early weaning off. Treat or prevent persistent inflammatory catabolic syndrome. What is persistent inflammatory catabolic syndrome in ICUs? It is ongoing organ dysfunction, inflammation, catabolism, results in sarcopenia, immunosuppression, and recurrent infection with metabolic derangements. Improve gut function, immune performance, and early recovery from organ failure, improve quality of life, and finally reduction of mortality. Okay, let's see metabolism during critical illness. This is very important when you are supplying the nutrition for the patients. There are two phases, acute phase and post-acute phase. In acute phase, early period, hyperactive phase of hemodynamic instability. This is the phase reason for the ICU admissions. Catabolism is predominating. Acute late period is a metabolic instability period and catabolism also there. Post-acute phase, the rehabilitation phase, the main difference in this here is the anabolist phase. Okay, what are the energy factors? Substrate used for energy generation in human body. Carbohydrate will generate 4 kilocalories per gram. Fat will generate for 9 kilocalories per gram, and protein 4 kilocalories per gram. Finally, these substances converted into the ATP in human body. In the critical ill, ATP production is severely impaired. You can see tissue ATP concentration in non-survivors in ICUs significantly low compared with survivors. High energy intake versus low energy intakes. In the extreme amount of fuel can impair endogenous repair mechanisms. The left side of the graph and recent research show around 70% of the energy delivery will show low mortality. Second graph from recent systematic review and meta-analysis show low energy intake during the critical illness causes early recovery from the ventilation. This is more favor in low energy intake. Okay. Here you can see gradually added enteral nutrition also not enough. Enteral nutrition also not enough to augment anabolism in rehabilitation phase, and must supply supplemental parenteral nutrition because you can see total energy expenditure gradually coming down and endogenous energy production also coming down, and the second week of the critical illness your energy input won't sufficient to fulfill the total energy requirement. In the second graph, will show if you feed early full feeding, your feeding level with the endogenous energy production will go above, and the hyperfeeding or overfeeding can occur. Okay. Many factors modify energy consumption in the critical period, including change in priorities. In the ICU, energy factors will reduce total energy expenditure such as sedation, pain treatment, muscle relaxant, shock, vasoconstriction, and organ dysfunction. And increased energy requirement can be seen in dyspnea, weaning, seizures, and inflammation, fever, and wound. Okay, let's go for the substrate of the energy. The preferred substrate for production of energy is carbohydrates. Critical illness, often insulin resistant and hyperglycemia can occur. Brain, red blood cells, immune cells, renal medulla and transplanar tissues of the eyes prefer glucose in the ICUs. Endogenous energy production by liver is increased in critical illness and does not decrease when nutrient and insulin are administered. Therefore, glucose and other carbohydrate administration should be done with caution and significantly impair the glucose level in the body as well. Okay, carbohydrate input in critical illness is maximum 5 mg per kg per minute. Excessive glucose-based energy provision associated hyperglycemia, enhanced CO2 production, enhanced lipogenesis, increase in insulin requirement, no advantage of the protein sparing action also. Enteral nutrition specific to diabetic type 2 might improve the glucose profile. Okay, in this study show high protein intake will reduce mortality, and every gram of the protein will increase the survival by 1%. You can see here reduction of mortality significantly with the higher protein intake. Okay, protein during critical ill. In this recent meta-analysis, higher protein intake more favor early recovery from the critical illness, and the higher protein intake more favor. Protein balance in critical illness. Here, intake of amino acid is parallel with whole body protein balance. For recovery, need more proteins, and it should be more than 1 gram per kg per day. High protein intake compared to the low protein intake, which will improve outcome. Protein 1.3 gram per kg per day should be delivered with exercises. Requirement adapted with weight, age, and metabolic status. Some patients with wound fractures may need higher protein intake, and some patients with such as acute kidney injury needs lower than 1.3 gram per kg per day. Exercises, physiotherapy may decrease protein catabolism. Okay, this will show you correct amount of macronutrient composition. You can see danger zones in intake and minimum zones of the intake as well. Please keep in mind that substrate metabolism is interlinked. If you supply high energy, definitely it will convert into the fat and is stored. Nutrient intake below the minimum level will induce nutrient specific deficits. Nutrient above the danger limit will either be stored as a fat or will be excreted as waste. Therefore, you have to supply in a very correct amount of the macronutrient. Lipids in critical ill. Meet caloric intake requirement with limited volume. Fulfill provision of essential fatty acids and component of cell membrane structure and fluidity. Regulate gene expression. Provide other non-essential fatty acid important in immune and other biological functions. Lipids should not be exceed 1.5 gram per kg per day or in around 100 grams of lipid per day for critically ill adult. Electrolyte, vitamins and minerals, especially potassium, phosphate and magnesium are very important component in critical care management. Potassium 2 to 4 millimole per kg per day should be supplied for deficiency. Phosphate 0.3 to 1 millimole per kg per day, and magnesium 0.2 millimole per kg per day in IV preparation and 0.4 millimole per kg per day for oral preparations. Calcium 0.2 millimole per kg per day, and trace mineral and vitamin should be given as a 1 RDA factor. Optimum vitamins including thiamine and vitamin D also should be supplied, because after initial 2 weeks in ICU, almost all patients develop vitamin D deficiency. Okay, let's come to the nutrition care process in critical illness. This is more important in nutrition management. Nutrition delivery care structure in hospital and ward in ICU. You should start with nutrition screening, assessment and reassessment, nutrition diagnosis, nutrition intervention and nutrition monitoring and evaluation. This is a fundamental of the nutrition care. Okay, let's start with nutrition assessment. Medical history and nutrition focus physical exams. Example, unintentional weight loss and weight loss percentage, physical activity, muscle mass and muscle strength. And in nutrition intake and related history, biochemical and biomedical investigation such as CRP, nitrogen output, fat-free mass through the BIA, ultrasound scan and CT MRI. Nutrition specific screening and assessment tools such as mini nutrition assessment, subjective global assessment, NRS 2002 and GLIM criteria. What is definitive diagnosis of nutrition? In European Society for the Enteral and Parental Nutrition recently declared this GLIM criteria. This is a global leadership initiative for malnutrition which can apply for ICU as well. Start with risk screening, and secondly, in the diagnostic assessment you have to take for the assessment criteria which, either phenotypic and etiological criteria, and finally you one etiologic criteria and one phenotypic criteria would end up with the diagnosis of malnutrition, and severity grading also we can done with this GLIM criteria. Medical nutrition therapy. What is medical nutrition therapy? Medical nutrition therapy shall be considered for all patients who are in critically ill and staying in ICU and HDUs. Oral diet should be preferred over the enteral nutrition or parental nutrition in critically ill patients who are able to eat. If oral intake is not possible, early EN within 48 hours in critically ill adult patients should be performed, initiated rather than delay in EN, and starting parenteral nutrition. When you start enteral nutrition, gastric access is more preferred route. In the case of contraindication to the oral and enteral nutrition, PN should be implemented within 3 to 7 days. Early and progressive PN can be provided instead of no nutrition in the case of contraindication for EN in severely malnourished patient. Enteral nutrition in critically ill. Advantages of enteral nutrition. It is physiologic. Improve immune mediators. It's tropic to the gut-associated lymphoid tissue and produce more and more immune mediators. Less demanding and risky, less expensive, maintain gut integrity and reduce bacterial translocation. When the gut works, use it. Enteral nutrition in critical illness and contraindication for enteral nutrition, complete bowel obstruction and post-operative stasis, severe GI bleeding, hemodynamic instability or bowel ischemia, high output fistulae, increased risk of infection, and ethical consideration situations such as in terminal care. Okay, this graph shows tube feed in supplementary supplying energy requirement in hospitalized patient. You can see energy goal and energy caloric intake. There's a gap between these two. This is why you must switch to the enteral nutrition from oral intake when your patient is not taking enough calories. Limitation for oral and enteral nutrition in critical ill. Mortality problem, especially paralytic ileus and delay in gastric emptying. Perfusion problem such as mean arterial pressure less than 60, impaired absorption, impaired exocrine intestinal functions, abdominal distension, increased abdominal pressure, risk of aspiration, pneumonia or impairment of respiratory function. Okay, parenteral nutrition. When enteral nutrition is not possible, administer not possible to administer because of the gut is not functioning as we discussed earlier, you have to go for the parenteral nutrition when the gut is not accessible and not safe as well. Unlikely to be effective sometimes in intractable vomiting also, we have to go for the parenteral nutrition in ICU and critical illness. Okay, what are the contraindications for parenteral nutrition? PN is not indicated if gastrointestinal tract is fully functional. No venous access, when the risk of the parenteral nutrition exceed the benefit. Prognosis of that don't justify the aggressive nutrition support. If your patient is not prognostically good, don't use parenteral nutrition ad hoc manner. And unstable conditions such as severe trauma condition, acute shock, severe diabetes mellitus, and sometimes non-hypersensitive to the component of the parenteral nutrition also you can't give parenteral nutrition. Okay, this is a nutritional monitoring part. Especially you have to monitor sodium, potassium, glucose, especially phosphate. In the patient with hypophosphatemia due to the repeating syndrome, or you have to see the electrolytes should be measured 2 to 3 times a day, and if they reduce, you have to supplement it if needed. Okay, just move for the pulmonary disease because this is your pulmonary sessions. Therefore, I would like to discuss a little bit more about the pulmonary disease and nutrition. I especially start with chronic obstructive pulmonary disease in the stable phase. Between 25 to 40% of the patient with advanced COPD are malnourished. Reduction of fat-free mass is significantly low in COPD with a severely impaired lung function less than 50. This is particularly marked during the acute exacerbation and hypoxia. Hypoxia might also be responsible for appetite reduction as well. Best survival seen in patients who gain the weight. Therefore, please consider for the nutrition for these COPD patients in stable phases as well. Other than that, tissue hypoxia, aging, physical inactivity, high resting energy expenditure, chronic inflammation, and some drug also causes this nutrition problem. COPD patient at risk of malnutrition. Who are the patients at risk of BMI lower than 21? Involuntary weight loss more than 10% from the usual weight during last 6 months. Weight loss during 5% or more during last month. Reduction of fat-free mass or lean mass. Reason for the pulmonary patients are at risk of malnutrition due to the low food intake, high catabolism due to the low-grade inflammation and nutrient wasting. Please keep in mind, being underweight and having low fat-free mass are independently associated with poor prognosis in a patient with chronic respiratory insufficiency, especially in the COPD. Okay, what are the nutritional intervention you can do for the respiratory patients, especially in the oral nutrition? The small feed and frequent feed. You have to give at least 4 to 5 feeding during the respiratory illness because reduce the disease-associated dyspnea. And energy-dense meal as well. What is the composition? Standard versus high-fat meal. Meal-related dyspnea not affected in chronic settings of COPD by meal composition, and it will further delay gastric emptying. Therefore, in chronic settings, you don't need to use high-fat meal. You have to supply protein 1.5 gram per kg per day, energy 30 to 35 kilocal per kg per day. Those oral nutrition fail, you have to go for enteral nutrition and furthermore parenteral nutrition as well. Vitamin A, vitamin D, zinc, selenium, phosphate, omega-3 and trace mineral also should be supplied. Keep in mind to improve the physical exercises. Okay, critical ill pulmonary disease and or acute exacerbation of respiratory failure. In here, artificial feeding should be given as enteral feeding. Enteral nutrition within 24 to 48 hours as a continuous feeding more favorable. High carbohydrate to fat ratio. High carbohydrate will produce more and more CO2, therefore reduce ventilator drive and high CO2 excretion. Therefore, fat percentage should be increased into this critical illness, 30 to 60% of the total energy from the fat. Parenteral nutrition also high lipid-based parenteral nutrition. Fat from the mixed lipid, shorter weaning time and low bacterial infection. Glutamine supplementation will improve the lung endothelial function. Vitamin and mineral also should be given. Okay, ladies and gentlemen, these are my take-home messages. Medical nutrition therapy of the critical ill patient remain a challenge but vital for the survival. Balanced macro and micronutrients should be given for these patients. Nutrition care process in critical ill is very important. Nutrition is very important for early recovery of the pulmonary disease, both in stable and critical ill period, and its rehabilitation as well. Therefore, please refer your patient to medical nutrition unit for proper nutrition care and follow-up plans whenever malnutrition is detected. Okay, thank you very much for all of you for listening this lecture, somewhat different to the pulmonary, no usual lectures, and any queries also accepted. Thank you very much.
Thank you very much, Dr. Malavarachi, as well as the other speakers, for that excellent overview of critical care and nutrition. So now the forum is open for questions. So if there are any questions? Okay. Until the questions are formulated, I would like to ask a question from probably Dilshan and Professor Dr. Vijay Kumar as well. Now, we saw that specifically when you're linking at the critical care patient with COVID and a patient with ARDS, who probably, as well as a person who has ARDS only, there is a difference between the strategies of oxygenation. You know, one will prefer HFNO, the other will benefit from NIV, especially in the COVID era. So do we have any pathophysiological basis for this difference?
So I think, again, that's why I think they have categorized the non-COVID versus COVID. There should be something different between these two groups. Because COVID is a viral pneumonitis that leads to inflammatory reaction. Whereas the other ARDS, if you take, they may be due to the sepsis, or maybe traumatic ARDS, or maybe acute pancreatitis, where your pathology may not be in the lung, whereas somewhere else. Whereas the COVID infection is basically in the lung, on top that they behave as ARDS. So now, if you take the criteria, the onset, the X-ray changes, and the PF ratios, and with no cardiogenic component, so they come into the category of ARDS. So they might behave differently to the with patients who have, non-pulmonary, non-cardiogenic pulmonary demand. So your strategies may be different. I think probably we have seen that during the COVID seasons that they were really difficult to ventilate, even when you're prone that their oxygenation has not really improved, especially when they are intubated. But the awake proning has worked for COVIDs, but there's no evidence at the moment for the non-COVID patients. So I know that's why the people are looking at different phenotypes of patients with ARDS. The COVID behaves as a different phenotype of ARDS, so strategies may be different. So that's why I think, I don't know, like the recommendation is to use NIV or high flow if you have, but I think if you can't keep them on NIV for a long time, so you might need to alternate with high flow and NIV if you have a COVID patients.
Any more questions?
Yeah. I totally agree with Dr. Dilshan. Initially, when the COVID hit the world in March 2020, everybody thought it's a coronavirus-induced ARDS, and they started treating the patients as such. And then there was an increased mortality. And a few months later, the British group came and said, look, this is not ARDS, this is a viral pneumonitis. So they said, start giving steroids as early as possible. So they have advocated dexamethasone. Of course, across the world, different people used different steroids, IV steroids, oral steroids. And then those who received the steroids got better faster and got released from the hospital. So they look similar, but they are so different, like chalk and cheese. And all that has been said about ARDS, all that management strategies didn't work for COVID for simple reason. ARDS is a lot of fluid in the interstitium, whereas in the COVID, there was no fluid, but a lot of inflammation. That's why steroids work very well. And that's the reason why in ARDS, in the early ARDS, NIV has been indicated. Some studies have shown very good results, but they said quote unquote early ARDS, not in a very established ARDS with a lot of PO to FaO2 ratio, which is being very low. So HFNO worked very well in COVID and not so much in ARDS. So they are so different, the pathophysiologically.
Okay, thank you, Professor Vijay Kumar. Any more questions? Right. I just want to put this question to Professor Narendra. Now, after COVID, the use of high flow nasal oxygen has been, quite popular, and a lot of people, knowingly or unknowingly, using high flow nasal oxygen in acute setting now. So, do we have now, I know that there are a lot of studies that have been going on. Do we have evidence to say that use of high flow nasal oxygen in acute setting has any mortality benefit?
Yeah, thank you for the question. After COVID-19, there has been a lot of increase in the HFNC. But as for now, in acute setting, the high flow oxygen doesn't have much more of the benefit as compared to the simple oxygen therapy. Acute settings are mostly a time constraint, and regardless of etiology. The important thing is to decide now and then itself. The issue is about to think about not only starting the oxygen, but regarding the monitoring the oxygen also. So it's better to start with the low oxygen, monitor it, go slowly, but go definitely. And most of the guidelines are, if you look at the guidelines are like, GPS in the known territory. But when you do a clinical practice, it's mostly acute care is an unknown territory. And clinical judgment is most important issue. And judgment has to be based upon the clinical as well as the SPO2 and other parameters.
Thank you.
In the interest of time, I think just a simple, quick question to Dr. Malavarchi. In a stable COPD patient, if the patient comes and sits in front of me, we know that the diet should be a little bit different. Any particular advice that we should give? Add a little bit of coconut oil, something like that.
Yeah, actually, the patient should be supplied with first high protein, because normal protein intake would be around 1 gram. At least 50% more should be supplied. And energy also problematic in these patients, because high basal metabolic rate also can be detected in COPD patients. Therefore, we have to supply adding coconut oil and other energy dense olive oil and other anti-inflammatory oils, not the most of the time inflammatory oil like some unsaturated fat. We have to supply at some, especially saturated or monounsaturated fats for these patients. It will improve the outcome, especially the weight gaining significantly improve the outcome.
So one quick question with the permission of the chair to Dr. Sajita. Should we check serum albumin? Is it a surrogate marker for the outcomes of mortality? Are there any studies which looked at serum albumin at admission?
The COPD patients? No, see, serum, especially in the serum albumin, is a very tricky, because serum albumin, most of the COPD patients have in low-grade inflammation. Therefore, serum albumin is a negative acute phase reactant, dramatically reduced sometimes in the patients. Therefore, we can't take as a significant nutrition status, but reduction of serum albumin below 25 or 20, it's significantly impair the prognosis of the patient.
So we are at the end of an interesting session, and I would like to thank my co-chair, Dr. Afra Sadiqeen, for chairing, and the speakers as well. Thank you very much, and hope you have a pleasant lunch and join the evening session as well.
Thank you, speakers, for that thought-provoking series of presentations. Now I cordially invite the chairpersons to present the tokens of appreciation to the speakers. Firstly, Professor Narendra Bhatta. Next, Dr. Dilshan Priyankara. Next, Dr. Vijay Kumar Ratnavelu. And finally, Dr. Sajita Mallavarachi. Thank you, sir. Next up, let me invite Dr. Bodhika Samarasekara, the President of the Sri Lanka College of Pulmonologists, to present the tokens of appreciation to the chairpersons. Thank you, sir. Ladies and gentlemen, lunch will now be served at the atrium. Please return at 1:30 p.m. for us to begin Symposium 11 on sleep.